Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I will be your host this evening. Given that tonight is a Thursday night, and it is Thursday, October 27th, 2022. Given that it's a Thursday night, we will be doing cases from folks' lists. I will ask if you've been in the hot seat, certainly Monday, Tuesday, or Wednesday of this week, please don't volunteer at first. Let your colleagues have an opportunity to practice. Certainly, once we run out of folks, I will be happy to take people that have been on or in the hot seat during those nights. So, as is my usual custom, we'll pause around 9:20 to try to answer any questions from the audience of cases that we've gone over, but we will go over them after each one. And I guess we'll probably stop around 10 minutes to 10 for the same thing. So certainly feel free to type your questions in, although I will ask for people's hands up if they want to ask their question verbally at the end. Okay, let's get rolling. Laurel, trying to unmute you.
Hello.
There you go. Hi, how are you?
Good, how are you?
I'm doing well, thanks. So are you a generalist or a specialist?
I'm a generalist.
Okay, just out of curiosity, when's your test?
In mid-November.
Oh, okay, so you're the 2nd November. Gives you a little bit of time.
Yeah.
Okay, let me just pop up your, hopefully in a second you'll be able to see your list. Okay. So patient number 3 had a diagnosis of endometriosis, dysmenorrhea, and pelvic pain. Was this patient, I assume this patient was not menopausal, is that correct?
She was not.
I guess the question is, I mean, she is 55, so statistically she's past menopause. How come you didn't try to treat her medically with the idea that in another 6 months to maybe a couple years, who knows, she would be menopausal and could avoid the surgery altogether?
Yeah. So this patient had been following my group practice for many, many years, and she'd had a diagnosis of endometriosis also for many, many years. Earlier in her reproductive years, she had been on birth control pills, and that did control it relatively well. However, she had required a couple surgeries actually to help fully relieve the dysmenorrhea she was having from the endometriosis. And then as she got into her late 40s, she started to have just recurrences of the dysmenorrhea, pelvic pain, and she didn't want to take the birth control pills anymore. At that point, we had lengthy discussions, myself and my other partners, over multiple visits about options for her medically, and that she may go through menopause in the next year or even sooner. However, she may have a period of perimenopause before that.
Did you try her on Lupron?
And
we offered her
GnRH agonists and antagonists, and she declined. I even offered to see if she wanted to try an IUD to see if that might help.
Well, I mean, what do you recall what her objection to the GnRH medication was?
She was very adamant that she was just tired of, I think she was missing work. She just didn't want anything to not work. And I discussed with her that the success rate of amenorrhea on these medications would be very high and that she would likely feel better. But she was just kind of very tired of this disease process and wanted definitive treatment.
Did you see any endometriosis when you did the surgery?
I did not.
What are some of the theories of spread of endometriosis?
There's spread retro, like through from the uterus back through the tube into the pelvis. There's chylemic metaplasia. I believe hematogenous spread. Those would be the ones I can think of now.
Okay. Um, so how come you took her? How come you took her ovary?
I, she had already had one ovary removed from a prior endometriosis surgery where she had a large endometrioma that they had to remove the left ovary, and she desired removal for definitive treatment of her other ovary. Um, because I did discuss with her that if there was endometriosis lesions outside of her uterus, then she may still have symptoms if I just removed her uterus and cervix. So if we were going to do this type of
So you
surgery.
recommended the RSO
For
or
definitive
radiofrection?
point, yes, my first recommendation was medical management. However, if I was going to do the surgery, I felt that this was probably going to be the best
What if
option.
she'd been 40, 45? What would you have? Would you still have taken that ovary?
I would have had a discussion with her about leaving both the ovaries, um, and discussing their benefits, knowing that there still might be up to a 20% chance that she may down the line need her ovaries out for recurrent symptoms. Um,
So when you do a hysterectomy on somebody for endometriosis, what is the recommendation to take or leave the ovaries?
I mean, I think for definitive treatment would be to remove the ovaries. However,
Um, Sorry, go ahead.
I think that there is some information that that there can still be some, yeah, I think the removal of the ovaries would probably be the recommendation.
Okay, well, again, how come you removed her ovary when you didn't see any endometriosis and she's not menopausal?
I wasn't sure if there was just endometriosis that I couldn't visualize. And I didn't know if before she went through menopause, if there would be lesions that would grow or become present that would cause her
Did
pain.
you did you put her on hormone replacement?
I discussed with her that I thought she should be on hormone replacement maybe for about a year, until potentially her natural menopause, but she was against that as well and did not want to do it. So she did not start on hormone replacement therapy.
Is she pain free now?
She actually had I saw her only twice since then, and right after the surgery, she had no pain and was very, very happy. And then afterwards, probably about a month after, she said she felt like a significant reduction in the pain, but it wasn't at zero.
Hmm. Um, Last question. I mean, do you think that the pain may have been generated from something else, like maybe irritable bowel or some other
I
GI
think
or GU?
possible. We had exhausted a lot of options. She'd done physical therapy, pelvic floor physical therapy. She'd met with a gastroenterologist and had a colonoscopy. She does have a history of depression and is well controlled. And she sees a therapist. And I mean, it could have been,
Is she on an SSRI?
she is on an SSRI.
Hmm. Okay. All right. Let's talk about this one. So some of the theories are spread. So you're right. Retrograde menstruation, coelomic metaplasia, hematologic, and lymphatic would be the other one. So the recommendation in general is when you're going to do when you have a patient that has, I'm going to call it intractable, that may be a little bit over dramatic, but discomfort from presumed endometriosis, the recommendation from ACOG is to just do the hysterectomy because most women will get adequate relief with just the hysterectomy alone. And again, you're right. There's about a 20-25% chance that she'll need subsequent surgery to remove one or both ovaries in the future. But that they recommend it basically in a stepwise fashion. Now, again, that's not 100%. If somebody's got, just socked in scar tissue, around both adnexa, or just terrible adhesions, one ovary's up by in the left upper quadrant. I'm exaggerating, obviously, but something, really heinous. That's a different story. It would have been reasonable. I mean, it's unfortunate she wouldn't go for the Lupron because at least that would simulate her menopause for her, and you'd be able to tell whether, hey, doing the surgery is going to be helpful for her or not.
Yeah, this was actually what I was worried about. I hate this case actually, but um, just for that
I mean,
reason.
I don't think it's that big a deal. Knowing some of the details, I don't love the case either because, I mean, if she were menopausal and you took her over at 55, definitely not a big deal.
Yeah, but
But the fact that she's not, I mean, she might have had periods for another 4 or 5 years, or she might have had periods for another 4 or 5 weeks. I mean, who knows? But,
yeah,
when someone's not menopausal and you do an oophorectomy, even if they're past the age of menopause, if we extrapolate the data, that probably is going to affect their life expectancy a little bit.
yeah.
So, any, I probably would have made her not sign a pack, but agree to go on hormones before I did the surgery. But I'm not saying you should say that. I'm kind of half kidding with you. Any questions about this one?
No. Do you think there's anything else I need to be like worried about for it, or like I don't know.
Well, you'll need to, if the case comes up, you'll need to, and this is kind of for everybody. You want to be pretty concise. They're not going to say, "Tell me about patient," number 3. They might say something like I did. How come you took out the right ovary?
Mhm.
So you're going to need to be very concise in terms of how you get to why you took out the ovary.
Right.
She had multiple prior surgeries, desired definitive treatment, she had a known history of endometriosis and tried to get her on medications, but the patient refused all that, wanted definitive treatment. And I counseled her about we should leave the ovary, but again, she wanted everything out. And this is what we did, at least to get to that point, and then they can ask you more details.
Right. Okay.
All righty.
Thanks.
Thank you. Okay, so Jordan, are you volunteering? Says you're self-muted, Jordan. There you go.
Yes, I'm here.
How you doing?
Good.
Are you a generalist or specialist?
I'm a generalist.
Okay. All righty. Give me a second. So patient number 4 is breach at term. She had a version which failed. What gestational age did you do the? What gestational age did you do the or attempt the version?
We attempted the version at 37 weeks.
Okay. Now, when did you discover this baby was macrosomic?
At delivery.
Okay.
We did not have she had a uncomplicated pregnancy, so we did not have a EFW on her, and she was
Don't you
measuring
normally do an
appropriately.
EFW? Don't you normally do a clinical EFW at term when you're going to either do a section or when they come in labor anyway?
Yeah. So via abdominal palpation and fundal heights, there was no suspicion for it.
Okay.
She also, if I'm remembering correctly, had a larger habitus, so it probably was not the most accurate.
So if you were to have obtained an ultrasound at term, how accurate is ultrasound at estimating fetal weight?
It can be plus or minus 15 to 20%, and it is less accurate at telling if a baby is macrosomic. It's better at ruling out macrosomia.
Less accurate than what?
It is a poor, so it is not as good at telling you if a baby is macrosomic. It's better at ruling it out. So if you get an ultrasound that shows that EFW is normal, that is better at telling you that the baby is not macrosomic than if you have an EFW that is macrosomic, that's not as accurate.
So, what are your weight cutoffs for offering a patient a primary C-section?
In the absence of diabetes, 5,000 grams. In the presence of diabetes, 4,500.
Okay. Now, this patient was breech. What are favorable prognostic factors for successful vaginal breech delivery?
So term gestation, EFW that is greater than 2,500 grams, complete breech, and multiparous are the ones that come to mind.
Complete breech, you said, of multiparous?
Mm-hmm.
Okay. Let's say this patient came in delivering, and the baby is delivering. His baby's delivered out to the chest. They call you because you happen to be at the nurse's station with another patient, and you go in, you throw in some gloves, you deliver the shoulders and arms, but you have trouble delivering the head. What would you do?
So I ask the nurse to apply suprapubic pressure to try to flex the head. I would do I'm forgetting the name of it, but I would place my fingers on the zygomatic process to try to facilitate flexing the baby's head. If it's still not delivering, I would assess to see if there's concern for head entrapment. If I'm concerned about, well, I am not skilled in Piper forceps, but if I had a colleague around that was, I would see if they could assist me with that. And if I am concerned about head entrapment, you could do Droshin's incisions. I think that's the name of it.
So what is head entrapment?
Head entrapment is when the cervix clamps down around the fetal head, and the fetal head cannot deliver.
So if if the baby had head entrapment, how are you going to do your more so smelly bite maneuver?
Yeah. So if they had head entrapment, I would not be able to access the face if the cervix is clamped down around the head. So I would not be able to.
So would you need to know that ahead of time, maybe?
Yes.
Okay. What are risk factors for head entrapment?
Risk factors for head entrapment are a preterm infant, less than 28 weeks, I believe, and EFW less than 1,800 grams are the big risk factors.
Give me 1 second, just making some notes. Okay. Where would you make Durson's incisions if you had to?
6, 10, and 2.
Okay. You mentioned that if the head were stuck and let's say there was no head entrapment, that if you had a colleague around, you would try Piper forceps. Let's say you don't have a colleague. What are you going to do?
Another method you can use to deliver a head that is not entrapped in the absence of Piper forceps is kind of the backward roll. So you attempt to flip the baby back over back onto the maternal abdomen to see if it will flex that way.
That doesn't work. What are you going to do?
You could try, I would attempt to do, I guess at that point I would do a laparotomy, and you could apply pressure to the uterus, essentially to have more effective suprapubic pressure.
Would you make a hysterotomy?
I would try that second. At first, I would attempt to apply direct pressure on the uterus prior to making a hysterotomy.
So if you've tried all these other things and then you've rolled the patient to the back and then you've given her anesthesia, how long do you think all that's going to take? Do you think the baby's going to still be alive?
Probably not.
So want to rethink those pipers?
Yes.
Do you know how to do pipers?
I do not know how to do pipers.
Okay. All right, let's stop here and we'll go over it, okay?
Mm-hmm.
Okay, so the ultrasound plus or minus 15 to 20% good, your 5,000 and 4,500 good. Favorable prognostic factors for a vaginal breech delivery. You said term, so that's correct, 37 to 40 weeks. You said EFW greater than 2,500, so that's correct, 2,500 but up to 4,000. You said complete breech. So complete breech is okay, but frank breech is preferred. Footling would be a no-go. Multiparous. So multiparous, sort of. They have to be vaginal deliveries. So, you want that the patient's had a full-term vaginal delivery previously. Okay? And then the other thing is you'd want to make sure that there are no intracranial fetal anomalies as best you can. So, no hydrocephaly or anything like that, because that would be a nightmare. All right?
Yep.
Boy, Jordan, you're awful quiet.
Oh, sorry. I'm
okay.
sorry. I'm sick. I'm drinking Theraflu. That's why.
No, you're fine. Okay, so first thing you want to do if the head's not coming is to do a vaginal exam, because you want to see, do you feel the cervix around the neck? In which case you have a head entrapment, or is the head in the vagina? Which again, if she's full term, is most likely the latter, but you can't rule it out without doing the exam. So situations where we might encounter head entrapment. You said preterm labor, so that's for sure. A preemie, because again, the head may be bigger than the body. In the case of a second twin, especially if twin B is significantly bigger than twin A, that would be another situation. If there are intracranial abnormalities like hydrocephaly, if there's extremely asymmetric fetal growth restriction, it'd have to be pretty extreme. So those would be the risk factors for head entrapment. Now, if you discover that the patient has head entrapment, one thing you could do before doing the Durson's incisions would be to give a uterine relaxant like terbutaline, and then see if you could reduce the cervix. If you can't, of course, the Durson's incisions, as you mentioned, and typically those are done at 2, 6, and 10, but we would try to do 2 of them first and see if we could get away with that before making the third incision. Now, assuming there is no head entrapment when we do our vaginal exam, then we would go to that more so smelly light maneuver where you were describing putting your fingers on the zygomatic arch, and baby would be back up. So the body would be back up to the ceiling, not facing the ceiling anyway. We would try to flex the head forward, trying to get that occiput from around the pubic bone. So we would flex the head. If that doesn't work, of course, suprapubic can be done simultaneously, again, to try to push that head forward to deliver. Now, if that doesn't work, what you described in terms of kind of folding the baby back on the mom's abdomen and pelvis, you can certainly try that. If that doesn't work, then you really have to do the pipers, and that's even if you've never done them before. So the reason to do them, if you don't do them, Jordan, the baby's going to die. If you do them and totally screw them up, it's highly unlikely that the baby's going to die. The baby could have marks around his or her face. There could be some other issues. You may create some maternal trauma, whatever, but it's not likely the baby's going to die. But even if the baby did die, If you don't do something, the baby's dead. The baby's guaranteed to be dead. So the reason why we would do Pipers in this situation, but we would not do a pubic symphysiotomy in the case of a shoulder dystocia, is because the risk to mom in this case is vaginal trauma. And I'm not trying to minimize that, but it's not likely to be a lifelong problem for her. Versus if you did a pubic symphysiotomy, it's likely she's never going to walk correctly again, and you're going to really mess up her urinary tract, either the urethra, the bladder, both. Again, including the symphysis diaphysis that you'll create. Does that make sense?
It does. So, so even if we're not skilled with Pipers, we would still say we would do them, I guess is my question.
Right. So
okay.
Correct. You have to you have to have a basic understanding of how they are applied. So typically the maternal left blade would go on first. And there's two ways to apply forceps. There's a wandering method and then a direct application. The wandering method is when you put the forceps blade in at 6 o'clock and sweep it around to where you want it on the fetal head. The direct method is where you apply it directly where you want it on the fetal head. So you put your hand in between the baby's head and the vagina, so the vaginal wall, and you'd slide your forceps along the palm of your, let's say, your right hand, because it's the patient's left. And you'd place the forceps there, and then you'd go to the contralateral side, do the same thing. And your pulling motion is going to be like a J. It's going to be a short down. You're almost flipping almost flicking your wrist forward, like you're waving almost, because you're trying to get that head flexed forward. So it's a short down and then a long up. It's the pulling motion. Got it?
Yeah.
Any questions?
No, I don't think so.
Very good. All right. Thank you for volunteering. Okay. So let's go. I'm going to mispronounce your name. Nikita, is it?
Nikita.
Nikita, sorry.
No problem.
Are you a generalist or a specialist?
I'm a generalist.
Okay. Give me a second and we will get your office list up. Patient number 3 is a 45-year-old G5 with mixed urinary incontinence, history of a sling, removed secondary to retention. She's got a BMI of 43, H&P cough stress test, urinalysis, urine culture, counseled on the management of mixed urinary incontinence, referral for urodynamic testing, a beta-3 adrenergic agonist drug, nutrition, exercise, weight loss, nutrition referral, case manager, and to the bariatric clinic. The cough stress was negative. UA was normal, urine no growth, improvement in urgency, and ongoing management. So, Nikita, what are risk factors for urinary incontinence?
So urinary incontinence, some of the risk factors when you have increased chronic abdominal pressure, so it can be seen with like obesity, and so that could be a risk factor for urinary incontinence. Also, risk factors can be based off of like diet. If they are consuming a lot of like irritants to the bladder, they can have urinary incontinence. Secondary to that, increased parity.
I'm sorry, what are the irritants you're talking about?
So artificial sweeteners, spice, caffeine are some of the irritants to the bladder.
Okay. So you were saying obesity, bladder irritants, what else?
Increased parity in general, just an increased number of pregnancies they had, no matter if it was C-section or vaginal delivery, increase risk for urinary incontinence. And then the more vaginal deliveries that you have, increase the risk even more. And then if
Okay,
you
so we
have
have
any,
parity. Go ahead.
and then vaginal deliveries.
I'm sorry, I didn't hear the last part.
Oh, I would say, and then just the increased number of vaginal deliveries in general compared to
Okay.
parent.
Okay, so anything other than these three things: obesity, parity, and bladder irritants?
Again, some any type of musculoskeletal issue where you have like weakened tendons can also cause that, because then they'll have weakened pelvic floor muscles as well. Smoking also increase for issues with urinary incontinence. And that's all I can think of for right now.
Smoking. I'm sorry, what was the musculoskeletal again?
Just if they have like any condition where they have like weakening like tendons. I'm drawing a blank on the name, starts with an M, but like if they have laxity in tendons, that can also cause it.
Okay. So, so this patient, so what made you think this patient had mixed incontinence instead of stress incontinence or instead of urge incontinence?
When she presented a couple years ago to the previous gynecologist, she had symptoms of both overactive bladder as well as urge incontinence at that time, and then had the management with the sling, and then had the complication, had it removed. When she represented, she was complaining again of increased stress urinary incontinence, and then also with urge incontinence as well.
So the cough stress test was negative. If you have a patient that comes to see you with, let's say, classic urinary stress incontinence symptoms, if you were contemplating taking her for a sling procedure, what type of workup would you do in the office?
So usually what I'll do is I'll do a history and physical. During that history and physical, I'll do a post-void residual. Also do the cough test. I'll either use the Q-tip test or look um, with my eye to see if they have any hypermobility in the urethra. If I can't eyeball it, then I will use the Q-tip to see if they have a positive Q-tip test. And then usually I would backfill the bladder with fluid. Well, first, before I backfill the bladder with fluid, I'll have them do a cough test with the empty bladder, see if they have any leakage. Then I backfill the bladder. At that time, I'm kind of assessing if they have urge at a certain bladder volume and when do they notice it. But then after I sense their urge based off of the volume in their bladder, then once I'm done with that, then I'll have them repeat the cough test with fluid in the bladder to see if they have a cough test. And then if they're not doing it if they don't have it when they are on the exam table, then you can also assess it when they are upright to see if they have it. And then usually if their story sounds like it, but I'm not getting a demonstration on the physical exam, then that's when I refer them to urodynamics.
So you're kind of doing, it sounds like, a little bit of urodynamics in your office.
Yeah, I do like a bedside cysto,
Mm-hmm. Oh, you do a
cystogram.
cysto too?
No, a
Oh,
bedside cysto.
cystometrogram. Gotcha.
Yes.
Um, now, what's a normal post-void residual?
So definitely anything above 150 is abnormal. Some groups say between 100 and 150 can be abnormal too, but definitely above 150 is considered abnormal among different groups.
What do you use in your practice?
So usually how I do it is if the void residual is between 100 and 150, I will repeat it at a later date. to see if it's
Okay.
consistently elevated, or was it just a one-time thing?
One-time thing. Why would they have a one-time thing of a elevated post-void residual?
Well, sometimes it could be elevated, or one of the times when it's not just one time is if they have a bigger bladder capacity. Other times is if it's just a one-time elevated number, even though each time I see a patient, the goal is for them to void before they see me. If they didn't, that could explain why I was elevated this one time, and why it wouldn't be elevated on a repeat, because technically it wasn't a true post void residual, because they waited too long between voiding and being assessed.
Okay. What's an anal wink test?
So this is where I take a Q-tip, and then have them kind of relax their pelvic floor muscles, and then take the Q-tip, and then you kind of swipe it near the anus, and then you should see the reflex of the anus retract. This is just to see if they have proper reflexes and neurological intact, if their neurological system is intact of the perineum. So with that, as well as checking for the bulbar cavernosus.
What nerve roots is it checking?
It is checking S2 through 4.
Okay. All right. So this patient was treated with a beta 3 agonist. What is a beta 3 agonist? What did you treat her with?
So I treated her with mirabegron, and so how it acts is that it kind of it decreased contractions of the bladder.
It decreases contract. So what is it used for?
So it's used for overactive bladder.
Okay. Did she get improvement?
So of those symptoms, she did have improvement in her urgency symptoms throughout the day. I don't remember if she had nocturia, but I remember she had improvement in her daytime urgency symptoms.
Uh-huh. Okay. Very good. Let's talk about this one.
Mhm.
So, let's see. Risk factors. First of all, we talked about risk factors. Oh, actually, let me ask you one other quick question before we go over it. Sorry. You mentioned bariatric referral. What are your criteria for a bariatric referral?
If they have a BMI greater than 40, without any comorbidities, they could benefit from bariatric surgery. However, in my facility is a little hard to get approval, just because this is not a service we have at my facility, and so we have to refer them outside of the IHS complex for these things. But then if they have a BMI of 35 and they have comorbidities like hypertension, diabetes, that is a usual criteria. But again, it's a little bit more with the logistics of will the patient referral dollars actually cover this? This is a procedure done outside our facility that could be a little bit more challenging for approval.
Okay. So Nikita, the whole last part that you just talked about, stricken that from the record, so to speak. We don't want to talk about money.
Okay.
You know, the question was, what are your criteria for bariatric referral? So I would just say, you know, patient with a BMI over 40, I would refer, or BMI over 35 with comorbidities, and leave it at that. First of all, you don't want to mention anything that might be suggestive of where you practice. That's the first thing. And then, I mean, you know, community hospital, rural setting, all that's fine, but not like a specific place. I thought you said IHS or something. Did I hear you right?
Yeah.
Yeah. So we probably wouldn't want to mention that. And then, you know, your recommendations, whether the patient can pay for it or not, are your recommendations. You may need to come up with an alternate plan. You know, I'm making this up. You know, if you recommend Lupron for a patient for endometriosis, that's your recommendation. If she can't afford it and her insurance won't cover it, you may end up putting her on, you know, birth control pills, for example. Fine, but your original recommendation, you know, you're making the best of what you have to work with, but your recommendation was still the Lupron, if that makes sense.
Yeah.
Okay. All right. So risk factors for urinary incontinence. So you mentioned obesity. I would agree with that. Bladder irritants certainly can cause urgency. You said increasing parity. I would agree with that. Smoking. You said tendon laxity. I don't know if you were thinking of a connective tissue disorder, perhaps, like Ehlers-Danlos or something of that nature, but you know, certainly possible. Other things I would think about, though, would be like COPD, you know, some sort of respiratory problem, diabetes, particularly long-standing diabetes, a neurologic problem, so like MS or spinal cord injury. These would be some of the things that at least come to mind in addition to what you said. All right, so, I forgot to ask you, what's a positive Q-tip test? So how do you determine if it's positive?
So if you use it with the Q-tip versus just looking at it from visual exam, it should sit on the horizon, and then when you have the Valsalva and it creases more than 15 degrees, then that would be considered a positive Q test.
Okay, thanks. All right, so let's talk about that one since we just talked about that one. So actually what you're looking for is correct, but it's not 15 degrees, it's 30 degrees. So you're looking for a change from baseline to, with the Valsalva of 30 degrees. Now, you can use a Q-tip. The other thing you could do is you could use the Foley. So when you do your post-void residual, you could just leave the Foley catheter and have them Valsalva and look for the change in angle with that. That way you don't have to introduce something else into their bladder, which may be uncomfortable. So post-void residual, the standard accepted is greater than 150. Your cough stress test was fine. One thing you didn't mention, though, was urinalysis or urine culture, which you'd want to make sure the patient had a negative urine culture. If you're evaluating your anal wink of S234 is correct, and it's with a Q-tip on the perineum looking for contraction of the external sphincter. Now, you did start to describe when you were talking about backfilling the bladder, so that did start to describe simple office cystometric testing. So typically how we would do that is, again, have the patient empty, straight cath for the post-void residual, and send the urine specimen off for culture. And then we'd backfill the bladder with sterile water, and we'd ask for the first sensation to void. So, you know, you talked about this, but I think we need just a touch more detail if we're going to explain this. Now, by the way, if somebody meets all the criteria for stress incontinence, for the four things we talked about, the Q-tip, negative post-void residual, positive cough stress, and negative urine culture, and her symptoms are consistent with pure stress incontinence, you obviously don't need to do this simple cystometrics. But let's say it's not clear and you were going to do it in the office rather than refer to urogynecology. So anyway, we were filling the bladder. We'd ask for the first sensation to void. We would take the syringe without the plunger in it, and we'd hold it up at the level of the urethra, still attached, of course, to the catheter. And we would ask the patient to cough. So when she Valsalvaed, we should see an elevation in the meniscus of the fluid that's in the syringe. That's normal. The question is, does she have continued fasciculations of that meniscus after the initial cough episode? So is the bladder continuing basically to spasm? If we don't see that, we would continue to fill the bladder. When do you really need to go? We would repeat the process of the cough, looking for the fasciculations. And then, you try to fill the bladder a little bit more and say, hey, when would you stop traffic and just, go on the sidewalk kind of thing. if you really had to go, and that would be the maximum bladder capacity. We would check that one more time with the meniscus, again, trying to distend the bladder and see if the distension of the bladder is causing this fasciculation, aka detrusor instability, which in turn may be causing an urge incontinence.
Mm-hmm.
So that's just a little bit more detail about the office cystometrics. Many of you will send them just to a urogynecologist and not do that if the diagnosis isn't clear. Any questions, Nikita?
No.
Very good. Well, thank you for volunteering. Nice job.
All right. Thank you, sir.
Sure. Okay, so Priyanka, let's see if we can get you off mute. There you go.
Hello, can you hear me?
I can hear you.
Perfect, thank you.
Are you a generalist, I think, right?
No, sir, I'm a MFM fellow.
Mine is a terrible thing to waste. Not yours, mine. Sorry.
Oh, no.
Shouldn't have, no, I didn't do that as a kid, but I was going to make the joke about don't do drugs as a kid. All right. MFM. So we have, hold on, there we go. We have your GYN list up. So patient number 13 desired sterilization. You did a laparoscopic bilateral salpingectomy. When you do a, well, first of all, she had a salpingectomy, and the patient above her had fallope rings. Why the same pre-op diagnosis, but the different procedures?
Absolutely. So the patient in case 12, actually, our recommendation was a salpingectomy for permanent sterilization. We had counseled her extensively on other options, including LARCs, birth control pills, implants, and the IUDs and vasectomies. However, she wanted permanent sterilization but did not want any part of her body removed due to religious reasons. So after extensive counseling, we decided to go ahead and move forward, and the fallope rings were the only other option that was available in our surgery center. So we were kind of limited by that. We talked to her about risks versus benefits, and that our recommendation would still be a salpingectomy with the decreased risk of ovarian cancer as a secondary gain from that. But this is what the patient wanted. So with shared decision making, that's the decision that was made.
So if you had done a bilateral salpingectomy, how much would you have reduced her future risk of ovarian or peritoneal cancer?
40 to 60%.
40 to 60, you said?
Yes, sir.
Okay. When you're doing a postpartum tubal, do you do a different type of procedure?
Yes, sir. So whenever I do a postpartum tubal ligation, I actually do essentially a mini incision right below the umbilicus, and then I do a pomeroy, or I do a salpingectomy if I can if I can see the fimbriae and I can visualize the whole tube easily, then I actually will do a salpingectomy even postpartum. If I cannot and I have trouble given the gravid uterus, then I will do a partial excisional procedure.
Well, even if you're doing a partial salpingectomy, don't you follow the tube out to the fimbriated end to ensure that you
Yes.
have the tube that you're working with?
I do.
So
I do.
you kind of have to see the fimbria anyway, right?
Right. So most of the time for postpartum, we do a full salpingectomy. Sometimes it's more just about like the technical difficulty of getting a good angle to do it. But in the past 6 months, I could say I think all of the postpartum tubals we've done have been salpingectomies.
So you mentioned you do pomeroy if you're, if you have to do a partial salpingectomy. Why do you select pomeroy?
Simply because that is the excisional procedure that I was trained with, and I'm more experienced with it.
Priyanka, no.
No. Okay.
Please, no. So this is not just obviously directed at you, and this is actually why I asked the question, to kind of make the point. please don't say on your exam that whatever you're doing is because that's the way you were trained. That's almost like raising the white flag, like I surrender.
Okay.
I don't care what else you say, but don't say that's the way I was trained. Because,
Okay.
you know, look, honestly, these are senior residency cases. So to be perfectly honest, you know, I'm sure you did whatever your attending was, you know, whatever their preference was, and that's the way it was. But now, you know, you're an attending, and so you're kind of the captain of the ship. So if you think, you know, if you were doing Yoshidas all the time in residency, and that's the way you were trained, but you think they're a big waste of time, you know, I would expect that you would have modified your, you know, your own practice. Now you're kind of on your own, so to speak. So,
Right.
you know, and so will the board. That's why this is the way I was trained. I mean, it doesn't fly. So,
Okay.
you know, a way to say that this is the way I was trained without saying this is the way I was trained is, well, you know, I do Pomeroy, and I like to do Pomeroy because I have the most experience with it. They're reasonably quick and easy to do. I've had no complications that I'm aware of. And so I've had good experience with it, and that's why I do it.
Okay.
You know, it's like it's almost like saying that's the way I was trained without saying that's the way I was trained.
Absolutely. Right.
Okay, and this is probably one of the more common times that it would come up. This kind of question. So back to our story. So what are excuse me? What are risk factors for tubal remorse?
So risk factors for tubal remorse would be if a patient has an unstable relationship, if this is recently in the postpartum period and there were any pregnancy complications, if the baby is in the NICU, or if the baby has any other significant medical problems, if the patient is under the age of 30, and if she has any history of like sexual abuse, intimate partner violence, those are all things that could increase the risk of remorse.
Okay, give me 1 second. So when a patient comes to you requesting tubal sterilization, what alternatives do you discuss with her?
Yeah, so we really kind of go through all of the different options, initially talking about, you know, things that she can do and things that her partner can do. So in terms of her partner, we do talk about a vasectomy being a quick procedure that can be reversible, and that's something her partner could do. Other things.
Hold on, I'm going to interrupt you for a second. So you can't see me because I'm not on the camera, but when you said vasectomy for partner, I got a big grin on my face. I was like, good for her. When you said it, didn't you say about a vasectomy which can be reversible?
I thought they could. Can't they put it back together just like we can technically with a tubal, like do a reanastomosis?
Yeah, but
or is that?
no, it's potentially possible, but my smile turned to a to a big frown after you said that, because you know, if we're talking to a patient about sterilization, we have to be convinced that they know that this is permanent, no turning back. You know, we're not doing the 5-year tubal or anything like that. So to insinuate that you bring up, you know, hey, I tell them it's potentially reversible, that's a yikes. Because if the patient's, you know,
I don't
out for
actually
something,
say that, but I felt like it was to be complete, but that makes sense. Okay.
no, that would be actually shooting yourself in the foot.
Yep. Fair enough. Okay.
The
So we talk
vasectomy
about,
part was great, but
okay.
but you know, you said what I wanted you to say. You don't need to answer the rest of the question. The vasectomy is the only thing they're going to care about if they ask you, because they know you can counsel a patient about contraception for her. But what they want to make sure is you're talking to her about her partner, because it's usually a smaller procedure and, you know, all that kind of stuff. So they want to make sure you're going to mention vasectomy. But yeah, it's kind of like I've had people say, sorry.
I was going to say, I will mention vasectomy is a form of permanent sterilization for her partner.
Right. I mean, you know, I've had people say to me, well, you know, they have like self-injectomy, and then they have like a 25-year-old, might be a G3, P3, whatever, but it says, you know, partial self-injectomy or, fallopian ring or something like that. And it's like, well, how come you did salpingectomies in all these people, but you did a ring here? Well, she's young. She's got a higher risk of regret. It's like, oh, no. It's because the comeback to that is if you thought that you might have regret, you shouldn't have done the tubal.
Right. Should have done a LARC or something else.
Just be careful with that. Okay, let's go over this one. So 40 to 60%, that's very good. Yep. Exactly what I would say. Again, we talked about not the way you were trained, so I think you get that. I think you got that point. Risk factors. So you said less than age 40. I can't read my own writing. I know you said sick child. Did you say unstable relationship?
Yes, sir.
Okay, that's probably what I wrote there. It looks like unstable. So recent postpartum, sick child, less than 30, parity less than 2, the intimate partner violence and abuse also would go with that. Patient is of low socioeconomic status, so they may feel they can't afford another child, for example.
Okay.
So these would be all risk factors. And then again, the vasectomy for partner is the critical part there. Any questions?
No, I think that's good. Thank you so much.
Thank you. Thanks for volunteering.
Yeah.
Okay, I'm going to stop here for a second for questions. So we've got a few in the box. Let's see. If we don't have a colleague around, should we say we would attempt Piper forceps or no? Yes, you would. Again, if you don't do something and the head's entrapped, the baby's definitely going to die. If you do the Pipers and you screw them up, it's still unlikely that the baby's going to die. Again, think about it. Potentially, I guess you could crush the skull. Again, very unlikely that that's going to happen, but I hate to say it, you're no worse off than if you do nothing. If you do nothing, baby's definitely dead. Okay, thank you for the question. Next question. Why is footling breach a no-go for vaginal breach? So footling would be a no-go for a couple of reasons. First of all, you can imagine the baby might be, the cervix might be dilated just a few centimeters and the baby's foot's able to pass through that. So, if we're thinking about a frank breach, so the legs are folded up and the buttocks is coming down, that's likely to be a fully dilated cervix. So we have a reasonable chance of delivering the rest of the baby. Again, with just the foot could easily come out and the patient's not fully dilated, so that would be a problem. Then the other thing is, and she could labor for hours till she gets to be fully dilated. The other thing is, with that foot could also come the cord. Not that cord prolapse cord prolapse would be a risk anyway, but especially with a foot as opposed to, let's say, the butt being there. So hopefully that takes care of that one. Are we expected to be able to describe simple cystometrics if we don't have incontinence on our list? It certainly could come up as a case of the day. 5 or 10 years ago, if you were taking your boards, I would say absolutely you want to know the poor person's office cystometrics. Not a bad thing if you know it now. You definitely need to know the workup for before you would take a patient for a sling, even if you wouldn't do a sling, even if you don't do them. You need to know the workup for stress incontinence for sure. And that was the 4 things we talked about, which included post-void residual Q-tip test or some proxy for Q-tip test. In other words, assessment of urethral hypermobility, urine culture, and off-stress test. Yes, that's right. So you definitely need to be able to describe those 4 before you would contemplate referring for a sling procedure again, even if you would send her to the urogyne. Okay, BTL. Do you have a recommendation for approaching different approaches that were dictated by insurance coverage without saying this directly? So, sure, good question, especially in light of what I said before in terms of your recommendation is your recommendation. So that theme would kind of still pass through here. What I would say is, some insurance companies are only going to cover a partial salpingectomy. So what I would say is, the question is, why'd you do a Pomeroy on this patient or a Parkland or whatever? Well, my preference was to do a bilateral salpingectomy to get the most risk reduction I could for future ovarian/peritoneal cancer. and I conveyed this to the patient. However, when the patient inquired with her insurance company about what her responsibility would be, she found out that she would end up having to pay for the whole procedure, which she couldn't afford. However, if she had a partial salpingectomy, she would have something that was affordable to her. So even though my recommendation was to do a total salpingectomy, I accommodated her and we did the partial salpingectomy. And then, of course, you should know what the reduction would be in ovarian cancer with a partial salpingectomy. And again, I'm going to have to encourage you guys, either individually or somebody can look it up while we're doing this. I think it's about 20% if you do a partial salpingectomy, but somebody can check us between now and 10 o'clock. Sorry. So hopefully that answers your question, Hannah. Okay, could you repeat the appropriate candidates for vaginal delivery? So I think these are the favorable prognostic factors. I think you were saying, or I think you're asking for vaginal breach. And assuming that's the case, it would be a patient that is between 37 and 40 weeks, a patient whose estimated fetal weight, the baby's estimated fetal weight is between 2,500 and 4 kilos, a patient who is a frank breach, although complete breach would be acceptable. Frank would be the preferred. Again, footling is a no-go. A patient who has had at least one preferably term vaginal delivery. Obviously, she said more than that, better still. And a patient where the baby does not have any known congenital anomalies, particularly, and I'm not talking about like a cleft lip or palate, known intracranial anomalies. Let's leave it at that. So like a hydrocephaly, that would be a no-go. Okay, specifically the weight cutoff. So if you're talking about weight cutoff for breach, again, it's 2,500 to 4,000. If you're talking about weight cutoff that we talked about with macrosomia, the weight cutoff would be 5 kilos. If you had an EFW of 5,000 grams and a non-diabetic, you could offer the patient a primary C-section, or 4,500 grams in a diabetic patient. If the EFW is that, you could offer a primary C-section. Does anybody know why it's lower for diabetes? Since I don't have anybody else breach, that'll be a rhetorical question. The reason it's lower is because with diabetics, there's thought to be more truncal obesity, so like more stocky kind of kids, bigger shoulders, that kind of stuff, as opposed to a baby who may be more uniformly big all over. All right, let's see. Breach. Oh, somebody had a question about breach vaginal delivery, and I think I just hit the delete when I was trying to open it. So please write it back in. I'm sorry. Yikes. How much do we need to know about the surgical urogyne procedures for prolapse and slings if we refer our patients to urogyne? Do we need to know the basic names of the procedures, or do we need to know how to do them and the details regarding their risks? So it would be very reasonable for you guys to have some basic knowledge. You don't need to know how to do a sacral colpopexy, but to know that some urogynes are leaving the cervix now to reduce mesh erosion would be something that's reasonable to know. To know at least high level how to do a sling and the purpose of a sling, and/or most frequent complication. That would be good to know even if you don't do it. Look, they may not ask you, but they might. And so in terms of, I would definitely know uterosacral plication or something like that in terms of a suspension. You don't need to know how to do a sacrospinous fixation, for example, but being familiar with what its intent is, what the intention is. And even if it's high level, like, we're attacking the vaginal apex to the sacrospinous ligament, that's better than nothing. So I think that's probably, I hope that answers your question. Now, somebody again had another question, which I apologize, I erased before we got to it. So if I didn't answer your question, please type it back in. It's an unanswered question. Let me see. Give me 1 second here, guys. Questions. So the question was breech vaginal delivery. I'm not sure. Oh, specifically the weight cutoff for breech vaginal delivery. Okay, I guess that was that. Okay, I think that we got all the questions, so that's good. Then we will go back to you guys. And nope. All right, I got to just get everybody's name back. Okay, so Stephanie, are you volunteering?
Yes.
Stephanie?
Yes.
Okay, great. Give me 1 second and we will get to your list. Are you a generalist or specialist?
Generalist.
Okay. And let's see, we just did GYN, so we'll do OB. Patient number 5 is a 33-year-old G6P5 at 40 and a half weeks. She's grandmultip and you induced labor. Everything was great. She delivered vaginally. What are grandmultips at increased risk for?
They're definitely at increased risk of postpartum hemorrhage. They can also be at increased risk of, well, rare, but uterine rupture can occur more often in grandmultips. Those are the main things that I think about.
Okay. Did you do anything special for this patient because of her grandmultiparity?
I try in general to avoid prostaglandins if we can, just to hopefully reduce that chance of uterine rupture. So usually a Pitocin augmentation or induction. And then I want to prepare for a postpartum hemorrhage. So I have medications usually at the bedside, as well as type and cross, especially if they have a low hemoglobin on admission.
Okay. So type and cross or type and screen?
Everyone admitted to our unit gets a type and screen, but I would specifically cross-match units if she had a hemoglobin that was low, like perhaps an 8 or so.
I'm sorry, what was the number?
8.
How come you use 8?
If they had a kind of a slightly above average blood loss, they'd be more at risk of going below 7 and possibly having symptomatic anemia requiring transfusion, whether it be immediate or postpartum.
So when you have a patient whose blood count goes to less than 7, I mean, when you transfuse a patient, do you transfuse them based on their number or based on their symptomatology?
If they have a number below 7, but they're really truly asymptomatic, they don't have tachycardia, they don't have orthostatic hypotension, they're ambulating fine and feel okay, then no, I wouldn't transfuse in that situation.
So it sounds like you use symptoms more than anything.
Mm-hmm. Yes.
Okay. I mean, do you think somebody who normally walks around with a hematocrit of, let's say, 26 or 27 normally is necessarily going to be symptomatic with a hemoglobin less than 7?
No, most likely not.
Okay. I'm going to do another one because this one was really quick.
Okay.
So the next patient down had, she's 40 and 2 days, had herpes. She was on antiviral prophylaxis but delivered vaginally. If she had an outbreak unbeknownst to you, despite your looking when she came in labor or when she was induced, if she had a herpes outbreak, so a recurrent outbreak, what's the risk of transmission to the baby?
With a recurrent outbreak, I want to say the risk of transmission to baby would be about 5% in a vaginal delivery in the setting of an active lesion or not fully healed.
What about in the setting, let's say it was a primary outbreak, what's the risk then?
Oh, definitely much higher. I would just be guessing, but I think more like 30%.
Okay. And what is let's see, 5%, 30%. What would be the potential sequelae, let's say in a recurrent situation?
I want to say it can be similar in that the babies can become systemically ill, including encephalopathy.
Okay, so do you think encephalopathy is likely in a recurrent situation?
Okay, potentially less likely because they would have some maternal antibody to HSV.
Okay. So encephalopathy or encephalitis. Any other risks that you can think of?
I think they can also get or have skin lesions. I can't remember right now off the top of my head.
Okay. All right. Very good. Let's go over these. I'm going to work backwards. So, risk of herpes in a recurrent outbreak that's unbeknownst to you, transmission is about 2 to 3%. There's a whole bunch of different things that can occur. They can have ophthalmic issues. They can have cutaneous manifestations. They can have encephalitis. They can have pneumonia. They can have disseminated disease. Most likely in a recurrent, we're talking about a more mild case. So we're talking about more likely that it's going to be cutaneous manifestation. When we get to primary, then we're talking about a risk as high as 50%. And in those cases, it's going to be more toward the less likely to be cutaneous alone, more likely to be something like encephalitis, or even worse, the disseminated disease. So, kind of makes sense. No antibodies, higher risk, and higher and more severe acuity. So, okay. So then we were talking about grandmultip patients. So you said postpartum hemorrhage, uterine rupture. Those would both be correct. Precipitous delivery would be another one. But other things would be diabetes, preterm delivery, small for gestational age or growth restriction, perinatal mortality, preeclampsia. And if you think about this one, it kind of all makes sense too, Stephanie, because, if somebody has 5 kids or more, it's not to say that they couldn't be 25 years old. Of course, we've probably all seen that, or somebody around that age anyway. Yes. But statistically, they're going to be a little bit older than, let's say, somebody who's having their first kid or second kid. Okay. So some of these things that we talked about are things that occur or increase in as a patient gets older. Mm-hmm. So, if you kind of start thinking about older patients and then the risks that they encounter, it becomes a relatively easy question.
Okay.
Any questions for me?
No.
Very good. Well, thank you for volunteering.
Thank you.
Okay. So, Michelle, are you, hope I pronounced your name correctly. Are you volunteering?
Yes, I am.
Okay. Are you a generalist or specialist?
I'm a generalist.
Okay. Give me a second and I will get your list pulled up. There we go. All right. Let's see what we got here. Okay. So, the patient number, I don't know, I was going to do that one, but Patient number 25 had STI screening. She's an 18-year-old nulliparous patient, and was positive for GC, chlamydia, and trichomonas, it looks like. Yikes. So first of all, did you send her for a full STI panel, given that these were all positive?
Yes. Whenever a patient comes in for STI screening, I always offer the full panel, including HIV and syphilis. But this patient declined.
So did you encourage her to to reconsider, given that she was positive for everything you tested her for?
I definitely did that. Yes.
Okay. Is hepatitis B or C part of your STI panel?
I actually don't test for hepatitis C, but in certain populations, this patient also warranted that have like high risk sexual behavior, hepatitis B.
So you test for B but not C. Is that what you said?
Yes.
Okay. And did you do expedited partner treatment? It says partner therapy, so I assume that's what that is, right?
So I actually did not make the prescription. I didn't do expedited partner therapy for this patient's partner because she said they were not together. So therefore, I recommended that if they did for any reason decide to reconcile the relationship, that partner should definitely be treated.
Well, shouldn't he be treated even if they're estranged?
Correct. He should, but she said that they're not talking anymore.
Okay. I mean, did you counsel the patient that she had an ethical obligation to alert him that he's positive or something?
I definitely did that as well. But I don't really know what I do after counseling her if she discloses or if she doesn't. What to do, excuse me, after counseling.
Okay. What if she had syphilis? Would that have changed anything?
Well, syphilis is a mandated disease. So by default, it would be reported to the state, and they would then do the partner tracking and then contact the necessary people.
Okay. When would you do follow-up testing? Or first of all, would you do follow-up testing on this patient? And if so, when would you do it?
I do follow-up testing in 3 months.
Okay. So you have resolution of infection. How did you know that because I see she only had one visit. So how did you know that the infection resolved?
Well, actually, this is a recurrent patient of mine, and so I test her about every 3 months. And at 3 months, she would. By the time I created the list, it was only one visit, but now I see her on a regular basis.
Okay. So how come you put her on Flagyl for 7 days?
I put her on Flagyl for 7 days to treat the trich.
No, I get that, but why did you give her the 7-day treatment versus a one-time dose?
Oh, I'm sorry. So the reason why I gave her 7 days as opposed to a one-time dose, I believe it was, I'm not sure at this time.
Okay. Last question. If she came in with pelvic pain on top of all this, what are your criteria for inpatient versus outpatient management of PID?
So my criteria for inpatient versus outpatient is one, that if the patient is unable to tolerate any foods or liquids, meaning that she wouldn't be able to take her oral medication. If she had a fever, persistent like systemic symptoms, those would be like the top things that would make me bring her inpatient. Or if for any reason
I'm sorry. Can you run those by me one more time so I can write them down?
yes, I'm so sorry.
No, it wasn't you. Me.
if she had systemic signs, like she had a fever, or if she was unable to tolerate oral things such as food or water, because she wouldn't be able to take her medication.
Okay, just the two things?
That is all I can recall at this time.
Okay, very good. Let's stop here. So very nice job. So, I mean, the thought about treating her for 7 days, on the one hand, with the flagyl, on the one hand, you run the risk of less compliance. On the other hand, if she were to start to have any PID type symptoms, I mean, you're kind of treating her almost as if it were for both. I'm not sure that the 7-day course might have a little bit better cure rate, but I'm not 100% sure on that at all. And you're treating her. Sorry.
I'm so sorry to interrupt. I actually think she had BV at the same time, if I'm not mistaken. And I didn't put that on the list because I'm like, technically that's not an STI. But I'm like pretty, like 95% sure she had BV too. And that's why I chose the flat 7 days.
Yeah, you could certainly mention that if that's the case when you go back and look. The other thing is she's on doxy, BID for 7 days. May just be, one might be reminding of the other or vice versa. So, certainly an acceptable treatment. You don't have to go with the 2 grams once. And as I said, I have a vague recollection that the 7 days might have a slightly higher cure rate than the other. Okay, so let's see. What was I going to tell you about this patient? So 3 months after for the test of cure, all that stuff was good. In fact, pretty much everything you said was spot on. The syphilis, you're right, would have to be reported to the health department, so they kind of encourage her from the health department to for patient tracking. In terms of inpatient treatment for PID, so patient can't tolerate PO. I'm sorry, inpatient treatment for PID. Patient can't tolerate PO. You said patient has a high fever. She's got an acute abdomen, unclear diagnosis, appears septic, failed outpatient management, or pregnancy. All these would be indications for inpatient management.
Thank you.
Thank you. All right, so I think we will get to the questions now. Give me 1 second here, folks. Okay, Hannah, thanks for looking this up. So still looking for this risk reduction with sterilization only, but not specific to partial salpingectomy from ACOG. The Swedish study, women who underwent bilateral salpingectomy had a 65% reduction in the risk of ovarian cancer, and women who underwent sterilization had 28% in reduction in risk compared to women who do not undergo sterilization, salpingectomy, hysterectomy, or BSO. So I think we said 40 to 60 for the salpingectomy. So I think we're pretty close there. Again, I don't know that it was from ACOG, but definitely have read other things that was a little bit lower. But thank you, Hannah, for checking that. 65 is good, guys, if you want to go with that. And I think if you're in the neighborhood, you're probably going to be all right. I think I guessed 20%, so it's actually 28% for partial salpingectomy. But so in other words, sterilization without complete removal of the fallopian tubes. Thank you for looking that up. That was very nice of you. Okay, the CT, let's see. New CDC STI guideline for trich treatment is 7 days with a flagyl. Thanks, Eva, for checking that out. We got another one, a second opinion on that from Christine, who concurs. The one-time 2-gram doses to treat men. So that may be at this point, but previously 2 grams was an acceptable regimen for women. I suspect that I think I was telling you, I thought that the 7-day treatment had a slightly higher cure rate, and now I'm even more convinced it must, because that's probably why CDC went with 7 days. Let's see, higher rate of cure. So that's just what we said. That's what this comment is coming in. Reduced rate of retesting positive at 1 month compared to the 2-gram dose. Again, higher rate of cure. So thank you everybody for pointing that out. Is Durson incision only for preterm? Not necessarily. Generally, yes, because we're going to get head entrapment. The most common cause of head entrapment is going to be a preterm delivery. Excuse me. But again, you could have a second twin that's with discordant growth. Excuse me. I'm sorry. You could have, I mean, the asymmetric IUGR would have to be fairly dramatic for there to be for that to be a cause. Again, it is possible, but it's not likely. And so the preterm labor again would be your most likely cause. The problem, I would say hydrocephaly would be another cause, and it is. The problem is by doing the Durson's incisions, you may still not be able to deliver the head because it's usually not the shoulder. It's usually not the cervix that's holding things up at that point. It's just filling the head's filling the pelvis, depending on the degree of hydrocephaly. So yeah, again, preterm is going to be by far the most likely scenario. Okay, another add-on for the 7-day regimen. So thank you everybody for checking CDC up for that. And Hannah, thanks for looking up the actual numbers for the sterilization. Well, guys, good news for you. You toughed it out, and we are at the end of our hour and a half. So I want to thank you for your attention. I think I'm the person in the host seat again on Wednesday. Sorry, not Wednesday, on Sunday. So I will look forward to speaking with y'all on Sunday. I hope everyone has a good weekend up until that point. And I know you're probably sick of studying, but keep it up. You're getting there. You're in the home stretch at this point. So thanks very much, and y'all have a nice night. Thanks, Eva, also for the good wishes. Good night, guys.